Hello and welcome to our lecture about lipid-lowering drugs. Here's our outline. We're going to talk about cholesterol and lipids and how they're made and transported in our body. And we're also going to talk about the medications and how they work to reduce cholesterol in our blood. Let's talk about cholesterol synthesis and transportation. It all starts with acetyl-CoA, which is then turned into HMG-CoA, and then HMG-CoA meets this HMG-CoA reductase, which turns it into mevalonate. Mevalonate is the precursor for cholesterol. Now, that doesn't just stop there. The liver needs to turn that cholesterol into something useful. And what it does is it turns that cholesterol into a lipoprotein package. Lipoprotein is exactly what it sounds like. It has a bit of lipids and protein. The lipids being cholesterol and the fatty acids that you want to transport to the rest of your body, and the proteins being the hydrophilic part, which helps it for easy transportation inside of the hydrophilic blood. Now, something you need to know is that as it's going into your blood, it's being packaged with a whole lot of fat. It originally starts off as very low or low density lipoprotein. And as it's going through your body has these lipoprotein lipases. This is being a lipase that breaks down the fat inside of a lipoprotein. And what it just does is you're opening up these packages and you're getting the free fatty acids inside for energy for your body. As your body is using this energy, it becomes more and more dense, i.e. it goes from very low density to just low density to high density. Something that you need to know is that LDLs do have receptors on the liver, and your liver can reabsorb them, and that's really good because what you're doing is you're reducing the amount of low density lipids, you're reducing the amount of the lipids inside of your blood, and you're reducing arteriosclerosis. Now, if you've used pretty much all of the lipids, it becomes a high density. High density because it's just nothing but protein. It's very dense. And this can be recycled as well into your liver. And once it's recycled into the liver, you can just package it and reuse it. So another source, instead of just making it, your body can actually get it from your intestine, from eating meat or eggs or whatnot, just stuff that has a lot of fat and cholesterol in it. So what you need to know is that it needs some bile to help emulsify the triglycerides. So once the bile helps with that, your body can then package it again into triglycerides and package it into chylomicrons, which can then go into the liver and then get packaged into this whole system, or it can just be used by your body and to make free fatty acids. Now, something that you need to also know is that cholesterol has its own little receptor for absorption. All right. Coronary artery disease is just caused by the buildup of cholesterol and fatty acids underneath the endothelium of your arteries. So what you gotta know is that these cholesterol and lipids will build up initially, and then the macrophage will attempt to clear it out, but it'll only make the plaque worse. So if you were to take a dissection and someone were to ask you, what would you find over here? You would probably the best guess for you to say is not just cholesterol or lipids or whatnot. You also want to say that there are macrophages in there. Now, eventually these plaques may rupture, and if these plaques rupture, they can cause a sudden occlusion of arteries. If this is in the coronary artery, it can cause an MI. So here's something that you need to be aware of is that high LDL suggests that the liver is sending fats outside of the body. That means that high LDL means that there's a lot of low density ones. That means your liver is sending fats to the rest of your body. And that means that there's too much fat. There's too many fatty acids, and that's really bad. But high HDL means that there's a whole lot of high density one. That means that there aren't a lot of lipids going in. They're actually probably going this way. And it suggests that the liver is resorbing fats from your body. It's actually reducing it. So that's actually really good for you. Statins are likely one of the more high-yield drugs that you're going to learn during medical school. They're very easy to spot because they all end in statin, like Lovastatin and pravastatin. Now, the mechanism is also fairly simple. It's with this very important enzyme called HMG-CoA. Now, just knowing this is not going to be enough. So you need to know that HMG-CoA inhibits the mevalonate synthesis, and mevalonate being the precursor for cholesterol, then you don't get a lot of cholesterol synthesis. But it doesn't stop there. because you are not making cholesterol, your liver still needs it. So what it does is it compensates by increasing the LDL receptors. So it'll increase these LDL receptors on its membrane, and it'll suck up all the cholesterol inside of your blood. And that's actually the major mechanism, the increase in LDL receptors. That's what causes you to reduce the blood cholesterol, not just inhibition of production. Something you do need to know is that it can cause hepatotoxicity, so you want to check for elevated LFTs. It's obviously affecting the liver right here. And it can also cause myopathy. Now, if you don't have enough cholesterol, cholesterol is important for stabilizing surface membranes. Surface membrane that you need to be very strong is your muscles. If you have weak surface membranes, you can cause myopathies in the muscles. And what you want to know is you want to check the CK value. I've showed you over here hematuria. It just means blood-looking urine. This is from the myoglobin that is released by your muscle cells, and your muscle cells then goes to your kidneys, and it can actually cause damage to your kidneys. And so after it causes damage, it can actually cause a lot of hematuria. Moving on to fibrates. Fibrates are also easy to spot because they have the fiber inside of their name, just like femburozil and bezofibrate. So I always just look for the fiber in the name to know that I'm looking at a fibrate. The mechanism, it works by increasing the LPL activity. So the lipoprotein lipase. Remember, lipoprotein lipase was all over your body, and what it does is it turns the very low density to low density and eventually to high density lipoprotein. And that just reduces the fat that is used in your body, and it makes your body use more of it. Now, something you do need to know is that fibrates, when combined with statins, puts you at severe risk for myopathy. One of the most common questions is that this patient is taking some drugs for cholesterol. It's not working, so you give him another drug. So he comes back 2 weeks later, and he's got all of these muscle pain all over his body, and is telling you, what did you do wrong? And the correct answer would be, you added fibrate to his statin drug. Another thing that fibrates can do is they can cause cholesterol gallstones. So let's talk about niacin, which is also known as B3 vitamin. It works by inhibiting hormone-sensitive lipase. Hormone-sensitive lipase being the enzymes in your adipose tissue that helps your fat just take everything out. I like to think of niacin as the kind of a vitamin that keeps everything inside, because not only does it keep the fatty acid from leaving your adipose tissue and going into your arteries, which is really bad for you, it also prevents your cholesterol and your fatty acid from being packaged into the VLDL. It prevents VLDL synthesis. That's probably the best one, the best thing that we can use it for right here. It reduces the VLDL synthesis, so it pretty much keeps the fatty acid and the cholesterol intracellular. So when you have no fatty acid to transport, it's because it's being inhibited, then you don't really need to recycle the LDL and HDL. So what you would actually see is an increase in HDL. So this over here would actually increase because all of these are going to eventually get turned into this, but then you're not really making any more VLDL, so what's the use of recycling them? Something that it can cause is facial flushing. I kind of like to think of it as if all the fats are stuck inside of you, then you're going to just have to get rid of them somehow, so you kind of burn them, and it causes just this like light facial flushing that you may see for the first couple of weeks. It may also cause hyperglycemia. Maybe your body's trying to compensate by increasing the glucose, is how I think of it, and hyperuricemia. All right, let's talk about bile acid resin. It is called bile acid because it traps bile acid, and it's called resin because it is a sticky, thick substance. They all have coles in their name, either with a CH or just a CO, but they all have coles, like cholestyramine, which has a tyramine, of course, and then cholestyramine. So that's how you know how to identify them. Their mechanism is that they bind onto the bile acid inside of the gut, and they inhibit bile resorption because they make this sticky, syrupy substance that kind of stays in your gut. And this makes it so that the liver actually needs to produce new bile. And how does the liver produce new bile? It has to use the cholesterol. So it has to reabsorb the cholesterol, probably absorbing LDL by increasing LDL receptors. and that actually reduces the cholesterol inside of your blood. And then your body is going to use it to make the bile to just help replace what it's losing from the bile resin. So this is the effect. This is how it effectively reduces the cholesterol inside of your blood. For a more detailed look, just so you can remember it, here's how a bile resin is. Here's cholestyramine. So cholestyramine has a tyramine right here, and what it has is it has this little chloride. Chloride is negatively charged. This chloride is going to go away, but the bile is also negatively charged, is going to take that place, and it'll get stuck. Now, when we see these brackets over here, that means it's repeating. It's a long chain. So instead of just being a small molecule that's easy to absorb, it's a long chain that's like long and sticky and just difficult to absorb. Now, something you need to know about the adverse effects is it causes a lot of GI upset. Just think of it as like this resin that's building up. It's all sticky and it's caused a lot of constipation and diarrhea, and you just don't know what's going on. And you also have decreased emulsification, so there's unabsorbed fat that's inside of your colon that is now causing diarrhea, while the resin that's building up is causing constipation. So just a lot of GI upset. It can also cause gallstones because your body has to try to replace all of that bile. Your body is used to reabsorbing the bile and just recycling, but now that it has to rebuild, like, produce everything from scratch, there's actually less bile for it inside of your gallbladder. And when there's less bile, that means cholesterol can build up a lot easier, and cholesterol builds up in your gallbladder and makes stones, causing gallbladder stones. Ezetimibe works by inhibiting the cholesterol receptor and preventing the cholesterol absorption inside of your intestine. So cholesterol can't go into your portal vein and can't get absorbed. So because it can't do that, your liver has to come up with a way. It can try to make some more, but really that's not going to be the major source of cholesterol for your liver. It's a lot easier for your liver just to reabsorb the cholesterol inside of your blood. So what it'll do is it'll increase the LDL receptors so it can reabsorb the LDL and take it out of your blood. This is really good for people with high cholesterol, effectively reducing the LDL inside of your blood. This is effective as an add-on for statin therapy. Remember, this is an add-on because you don't want to use a fibrate as an add-on to statin. It's more preferable for you to use ezetimibe so you can reduce the risk of myopathy. Now, as you would imagine, one of the adverse effects is going to be diarrhea. All this cholesterol that gets stuck in your intestine is going to go down, and it's going to cause a lot of diarrhea inside from the buildup of cholesterol in your gut. Now, how are you going to use this information? Just remember the mechanism and the adverse effects. They shouldn't be too complicated. They should be fairly straightforward and to the point. They love to ask about the effects of each one. So what you need to know is just memorize this table right here, which I'll get to in a little bit. So some of the more common questions would be a past medical history of hyperlipidemia. He's taking medications from his primary care physician, and then you get another drug added. He returns after a couple of weeks and he's got generalized pain and a high CK in the labs, or creatinine kinase. What is the cause? And you just need to look for something called statin/fibrate myopathy. They might just be vague and say the drug that you added or whatever. So something you need to know is what they affect the most. Statins are used because they affect LDL the most. That's what you need to look for. Fibrates, we tend to use them just because of their effects on triglycerides. Niacin, we like them because they have a strong effect in increasing HDL. Bile resin and ezetimibe reduce the LDL somewhat. All right, and that's it to it. Thank you.